Today I will discuss on arthritis. Especially I want to differentiate between the rheumatic arthritis and rheumatoid arthritis. There is very confusion in among the general patient that usually when they have narrated their complaints regarding the arthritis, very casual mode they often say that I have rheumatic arthritis. But you should know that there is a certain difference, that is rheumatic and rheumatoid, Helen difference. So rheumatic arthritis, one first I should say about the rheumatic arthritis. It is usually said that rheumatic arthritis actually it is related to carditis, that all form of inflammation of the cardiac layers. So carditis in all form, and with the migratory polyarthritis, the arthritis is in the big joints, one after another big joints. There may be chill, there may be fever. That's why it is said that rheumatic fever. So rheumatic arthritis usually affect the big joints one after another, and migratory polyarthritis and usually affects one after another with the history or not history of chill and fever. Fever may arise not, but what is important, that is it is usually complication or sequelae of any streptococcal infection. That streptococcal infection may be due to sore throat, maybe due to that type of infection of tonsillitis and upper URTI, upper respiratory throat infection, maybe due to even scabies or skin infection. So history of streptococcal infection is very important during taking history. So this is rheumatic arthritis, and it usually occurs in the adolescent period, usually from the age of 5 to 6 years up to 15 or 16 years or 17 years. They are very prone to develop this type of rheumatic fever, but it may appear in the latter part also. So this is whenever the arthritis, usually there is one criteria, that is Duckett-Jones criteria. There must be carditis in any form, there must be migratory polyarthritis, and one typical nodule is observed, that is very typical to rheumatic fever. There is Assoph's nodule, very important rheumatic nodules, and the Sydenham chorea. This is not very common, but the chorea, one type of involuntary movement, may be seen often in females. So these are all major type: the polyarthritis, migratory polyarthritis, carditis, and these type of rheumatic nodules, which is often said that erythema marginatum, erythema nodosum, like that. And in the minor carditis, minor form, there is a ECG changes, arthralgia, not the arthritis, arthralgia. All those are minor types. So whenever it is rheumatic arthritis, it will affect heart, or if it is right now it is not affecting heart, but the every probability that it may affect heart later stage of the disease. But heart is very much related to this rheumatic arthritis, and the streptococcal, post-streptococcal sequelae is very much important. The ASO titer, it should be very high. ESR should be very high. There may be ECG changes also. So these are the things which are very much related to rheumatic fever and rheumatic arthritis. So please don't forget the big joints, migratory one after another, ASO titer high, and chill and with rigor fever type. These are very important part, which is very important also, that if we go through the culture of the swelling of the joints, usually it becomes sterile. There is no bacterial or any type you can find. So it is rheumatic arthritis. In comparison to that, whenever we will go to the rheumatoid arthritis, it usually affects mainly the small joints, and usually the first, this is the fingers. These joints are very much prone to develop rheumatoid arthritis. Rheumatoid arthritis, the crippleness, the deformity is very characteristic of this rheumatoid arthritis, which is not characteristic of rheumatic arthritis. Rheumatic arthritis deformity is not common. This is totally uncommon, except one or two Jacquard's arthritis in rheumatic arthritis. But rheumatoid arthritis, deformity is the characteristic and usually affects the small joints. In rheumatic, it was big joints. In rheumatoid, it is small joints, and one after another also symmetrical. Left and right side symmetrical movement, symmetrical appearance of these joints of rheumatoid arthritis, very important. X-ray findings, we may find the erosions of the bone the mouse eaten the cartilage, there may be destruction. We know the pannus formation in the pathology. So the destruction of the affected joints, mainly the small joints, may affect then the big joints, but especially it is the characteristic of small joints of rheumatoid arthritis, and which is important here, that is the investigations of RA factors. Nowadays it is more specific anti-CCP. So anti-CCP positive, RA factor positive, with the symmetrical involvement arthritis, especially of the small joints, these are all very characteristic of rheumatoid arthritis. So we must not forget the deformity is the characteristic of rheumatoid, small joints affection is the characteristic of rheumatoid arthritis, anti-CCP positive, RA factor positive, these are all only anti-CCP positive. It doesn't indicate that the patient may have rheumatoid arthritis. With the presentation of the clinical features, even we have the criteria of the rheumatological associations, at least 3, 4, 5 criteria must be there. Morning stiffness is very characteristic of rheumatoid arthritis. First 30 minutes morning stiffness, it may appear at any age, but usually it is not very common to the very older age, because it is a type of autoimmune disorder. So you know better that autoimmune disorders in the third phase, fourth phase, 30, 40 years, these are the very prone, they are very much, these ages are very prone to develop rheumatoid arthritis. So we should not confuse about rheumatic and rheumatoid. There is clear differentiation. Rheumatic is the big joint, rheumatoid is the small joint. Rheumatic, one after another migratory. Rheumatoid, bilateral symmetrical appearance. Rheumatic, no deformity except one or two variety like Jacob's arthritis. Rheumatoid arthritis, it is deformity is the characteristic. The ASO titer positive in case of rheumatic fever with involvement of heart. Rheumatoid arthritis, it is the anti-CCP and RA factor and high ESR. ESR may be high in the both, but if you compare the very minutely, then only ESR high, high ESR is very characteristic also of seronegative rheumatoid arthritis. There may be anti-CCP negative, RA factor negative, but the clinical features, both the small joints involvement, it may appear in rheumatoid arthritis. So even being a negative anti-CCP or RA factors, patient may have rheumatoid arthritis, which is called seronegative rheumatoid arthritis, and in those cases ESR may remain high. So whatever may for these diagnostic part or the clinical features or the investigations, but from a homeopathic point of view, as our approach should be the same, the individualistic concept, constitution, what are the accessory circumstances, why it developed, like in rheumatic. From materialistic point of view, post-streptococcal infection is one most important part. But to us, the past history, the family history, the history of the present complaint. So we should make the totality in the real form. The patients in the society, we will consider the background, we should consider the society, we should consider the past history, family history, the very important part, that is the generalities. Patients, what is the desire, aversion, intolerance? You know, we as a homeopath, we all know the details of our case taking. So to take the individualistic case taking is very important. Even a good case taking will decide that whether we will take this case or it is under our purview or it is not in the curable stage in case of rheumatic or rheumatoid. Because in case of incurable stage, we have to give, I believe, that even in incurable stage, homeopathic constitutional treatment is the best palliative, but we may have to take the help of any auxiliary methods also. So we may have to take the help of other physiotherapies or anything other measure, but we should not believe that any type of rheumatoid arthritis is not under domain of homeopathy. It is not like that. It depends on the stage. Whether if we have diagnosed it is very early, the pathology is not too far, so very good constitutional treatment, even being autoimmune disorders, these rheumatoid arthritis, our approach, constitutional approach will give good result. It is same to rheumatic fever also. So rheumatic fever also, our approach, homeopathic approach will remain same. Here diagnosis is the matter related to the patient's confidence, just to gain your self-confidence, also to diagnose, because we have to diagnose for the prognosis part of the part and what is the stage of the disease. But The medicine selection always on the constitutional treatment. As my experience of last 30 years, I have seen like Thuja like medicine is very, very good medicine. Even Thuja, Medurinum, Lycopodium, there are so many, even Bryonia, so very wonderful remedies which act, but always on constitutional. We have to be very individualistic approach in all those cases. But where to refer or where to treat, these depends on your particular stage of the disease, that we should know. Aconite is very good drug in case of rheumatic arthritis. Like we have very small remedies, rheumatoid arthritis, but it is also very abused. The very small remedies also I have seen in rheumatoid arthritis like colchicum or any other. These are my personal belief, my personal experience is that in case of rheumatic or rheumatoid, we have to go through the constitutional approach, very ascending dose of 50 millisimal or centesimal as per organon of medicine approach we must go. And if any acute exacerbation appears, we have to take again the totality. On the basis of that acute totality, we may prescribe few small remedies, but never ignore the indications. You have to find out the indications, and I believe that in every condition there is some indications to prescribe a good remedy. If you are not getting any indications, that then it is also indications that patient is not in curable stage, she or he in incurable state. So in that case also palliative method also on the basis of symptom totality. So our approach should not be different for rheumatic arthritis or rheumatoid arthritis. The approach should be same, but the management different, the prescription may be different. It is always based on the indications of that patient at that stage at that time. It may differ with the after 1 year. It may differ with the accessory circumstances, but we have to find out all those accessory circumstances. We have to talk with the patient. We have to make the bonding of the patient. If the patient is not in a stage to speak much more, you have to make the totality from his relatives. Everything is written in organon of medicine. Everything, the direction is given, but we have to apply it, and we can modify it accordingly. We may customize it accordingly. But the very basic principle is the constitutional approach to any disease. So today I will only discuss on rheumatic and rheumatoid. So in the next video, I will go through the most common degenerative disorders, that is osteoarthritis and the hyperuricemia and gout. Thank you.